Hello and welcome to CTN. To learn more about the show, please visit ciotalknetwork.com. And the topic for today is optimizing healthcare IT budgets, balancing security, efficiency, and innovation within budget constraints. So we all know that healthcare IT budgets were not ever enough given the number of things we are trying to juggle. We want the absolute greatest patient care. We want to comply to the regulatory standards. We want to be innovative so that we can be competitive. And we have to make sure that all of this happens without any compromise in the quality of overall experience that is being delivered. Well, not as easy as someone would think. So what is it that the healthcare IT leaders can and are doing to juggle and make the most of the IT budget assigned to them? So to discuss this, I have Robert Eardley, who's the Senior Vice President and Chief Information Officer with University Hospitals. Hey, Robert, how are you?
Hi, good morning. Hi, Sanjog, and to the audience listening.
Great to have you, Robert. So as I painted the picture, and I'd love to hear from you that this beast of that we are dealing with, which is a lot of different tentacles it has, which is healthcare. And you are sitting at the very helm where you are dealing with IT, and which IT has become the very DNA of a healthcare organization, any healthcare organization for that matter. And then we bring budgets where there is never enough budget. Give us a glimpse of what's the life in the day of CIO who has to deliver the moon and also has a limited budget?
Yeah, thank you. So at university hospitals, we've been on a journey at least over the last 8 years or so to really collapse our IT portfolio. And so this is in a marketplace where we've had a number of acquisitions of various hospitals in our market, which is Northeast Ohio. And so as we've moved forward, we've worked really hard to explain in simple senses the idea of collapsing our portfolio to a single electronic health record, a single ERP, enterprise resource planning, a single time and attendance system, and the rest. And so we've worked really hard at that. So we've acquired 5 hospitals a few years ago. We've acquired a regional hospital system that had separate products in play, and then ourselves historically as university hospitals, we had different software systems. If you were in one of our physician clinics, that was a different one, and if you were in an inpatient in one of our hospitals, that was a different software system. If you got a bill, another software system, etc. So we've spent hundreds of millions of dollars over the last 7 years collapsing those to a single product line largely. And so I'm proud to say now, after that multi-year journey, we really have the same product at all of our sites of care, all of our facilities that schedules you, that bills for your services, that documents your care if you're in the emergency department, that stores your image, which in our world is called PACS. So we had a big investment in electronic health record, which was over $450 million. We acquired those hospitals. We had $125 million there. We acquired a regional health system that was $38.5 million there. So these are some big numbers, right? Is what I want the audience to know. And the big numbers are in spirit one-time investments to get to this portfolio that is streamlined. And so really this year coming into 2024, it's the first year in the last 10 years we've really had this streamlined portfolio. And so those are the one-time investments almost more in the past. And so now my challenge is to really prove out the efficiency now that we have those streamlined portfolio, that our cost of delivering IT services can be more cost efficient. And that's where we've been spending a lot of time now. And so we have less of the big project funding needs and more about moving to our future of, like the spirit of the question, innovations in different areas that allow us to continue to advance. So as we're preparing our next year's budget, that's where we're spending a lot of time is, what is the required investments and what are the innovative investments. And we can explore more into that as we move forward.
So since you acquired organizations and you had to bring them together, so consolidation is a one-word substitution of quite a few things that you did. So you did simplification, you did rationalization, you did consolidation. And that was the need of the hour. And I'm sure there was a business case and thus funding was provided. And at the end of the day, the idea was more to create value versus just consolidation for consolidation's sake. So as the business case was created for the budget, or the budget was created for this consolidation, it might have had two phases, right? One is, okay, we have this 800-pound gorilla, we got to make it lean and bring that all together. But now phase two, now that you got it, what did I get out of this? Number one. Number two, my needs are going to continue to morph. Yes, you brought that on one system, but then you still have to continue to push forward. You still have to have regulatory standards and efficiency and innovation and patient care levels, which kind of are becoming more and more demanding. So are the management, the constituents within the management, are they looking at your next phase differently? Because earlier it looked like it's a cost of doing business, so the money was assigned. But now you come to the same status as most healthcare organizations are, who have to ask for budget, and it's not going to be as easy to come by.
Mm-hmm. Yeah, so is background on our integrated electronic health record project. This is a project to move to Epic, an integrated electronic health record system. That was a classic return on investment business case. So the way that we sold that to our senior leaders in the board was, if we invest $623 million, we would get a return of about $120 million a year. And we had about 15 different categories that we outlined where we were going to get that return. And this is our first year live. And so it's appropriate for the audience to wonder, are we tracking against those original 15 that we sold in December of 2020? And we are, and we're achieving those benefits. But that is proving out investments we've already had in the past. As we go forward, now that we're fully integrated, now the challenge is really being able to balance the investments in IT with the investments in the rest of our clinical enterprise, whether it's MRIs, whether it's more nurses, whether it's more equipment. And so the one way or one technique that I do on the capital side, I start with the same, really about 7 buckets. In the first 2 is security and reliability. And so that's the foundation if you think of the triangle, right? The foundation is security and reliability. And so I start with a story where we have to refresh our network equipment, some of our computers, some of our phone systems that are 7, 8, 10, 12-year-old equipment. It's kind of unsexy because you're replacing stuff you already have. And it's not the innovative new, but it's necessary. And that's part of the role of the CIO, is to balance some of the necessary replacement with some of the innovation, really cool, boy, we're doing stuff really differently. And so I talk about our investments in infrastructure, and people have heard this now a number of years in a row. So it's starting, people are getting acclimated. When I talk infrastructure, it's the big 5. We have network, we have unified communication, we have data center investments, we have servers and storage, and end user computing, kind of the laptops and desktops. Now, most of the senior executives, they can get their mind around end user computing, the actual computers you touch, but not the rest. And so because of this rhythm of, now keep in mind, there's the big 5. It's a big number every year to replace roughly 8-year-old equipment. I'll average that out. And then we have an investment in information security, and we talk through that. And then we move on to all the other needs, upgrading our systems, innovation, investment in generative AI. And so it really, we allow ourselves to let that build on top of those first 6 always come first. We have 5 infrastructure investments, and then we have information security investment. And then we start to dole out the dollars, beyond that.
So the investment is made, and after the big bang, or rather not a big bang, but a necessary investment that you had to make to come to a point where you can say, yes, now we have the foundation to grow from, right? This point onwards, you got to be able to continually show value creation opportunities, which will allow you to make subsequent business cases, to be able to get the funding and then show ROI, for you to have the capability and the credibility as IT department to go back and ask for more. And given that at some point after your initial capital investment centric effort that was done, now you are operationalizing it. And not every company will be as fortunate to have such projects happen on a regular basis. They will be working on not exactly break fix, but they will be required to keep the lights on, plus of course, stay current, stay competitive, etc. And that's where they're struggling with the budget. So maybe people can learn from you those magic recipes that you've used, that every time you go to your management and ask for money, you get it, and you get more than you wanted it. So you had the luxury of putting it in the places where it is supposed to be, and you get the innovation going and the outcome that is desired. What is it that you're doing differently?
Well, I think on the really big ones, from the past, they were unique because they really stood on their own business cases. So I don't want to stay on that for too long. But when you acquire a hospital, you have to move those over to the systems that you run. And that's a little bit cost of doing business. There was the discussion about what's the return if we go to an integrated EHR. So that's also now in our history. And we're tracking those benefits, as I mentioned before. But you're right, as we move forward, we're now into almost the dogfight that so many organizations find themselves in. Are we going to invest in a new MRI? Or are we going to invest in the new IT system? And so the reason we start with those 6 on the refresh, almost because they are unsexy, right? How much do we need just to keep the core network running another year? And we try to get ourselves through that so we can really start to debate the things that are discretionary. We could upgrade a system, or we could, as an organization, invest in elevator maintenance. It becomes very tangible that way. And so how we do it within IT and then with university hospitals, safety is always paramount. So if there's a business case where it truly is patient harm or patient safety item, then those get funded first. Next really is around growth opportunities. If there's a clear business case where there is a return, there's market share growth, there's volume growth, there's a larger capture of the revenue cycle, those tend to get funded because it's very line of sight that those become self-funding. Now that can be a challenge, as your audience will know, but those will be self-funding. And so the ones that are harder are the ones where it is around patient satisfaction, provider satisfaction, maybe 10 minutes of efficiency across a lot of people, but no FTE reductions. What we do is technique-wise, we really rally around a 2-page business case, right? This is not rocket science. On the first page, it's what are you trying to do? And you outline on the first page, what are those benefits? And some of them that might be, we'll call it the softer benefits, the patient satisfaction or the 10 minutes per person efficiency. We outline that. And then the second page is this a classic financial year 0 investment year and 5 years of return. And some of those, we don't have dollars in some of those out years. We have the cost of the software. We have the cost to implement it. In some of those business cases don't have dollars on the top line, which is benefits. And so that is really where you have to understand and articulate this is an efficiency driver, or this is a patient satisfaction driver because they're going to get a text reminder. You can do enough work, I'm convinced, that you can always bring it back to a financial number. You could use enough assumptions, you could always bring it back to a financial number. sometimes that process is probably takes more time than it's worth. And so I think it's really about walking in with the business case and knowing what you believe are some of those soft returns, explaining those well, and then having the modesty that the organization is trying to balance an item like that with a new MRI. And if you explain it and you're articulate, then the organization will make as smart as a choice as they can. And you don't really win or lose as an IT presenter. You don't lose if your investment didn't get funded. If we're able to buy a new MRI, right, we won as an organization because we were able to invest in our future. And so that's how I kind of frame it.
And when it comes to the newer AI-centric efforts that are happening, whether it's virtual healthcare or other ways of infusing AI across the DNA of an organization, there would not be any leader, whether business or IT, who could bet their paycheck on what's going to work and not work, because it's kind of new. But at the same time, you can't afford to be becoming the second, third, or the fourth mover either, because your competitors are doing this. So when you got tight budgets, why I preface it with tight budgets, or where there are very careful scrutiny of every request that comes to your management, and you're supposed to handle that budget or allocate it in a certain manner. What is your approach as a leader to look at these seemingly promising avenues where investments must be made for it to give us return, but you're not sure. Yet, at the same time, you also are going to give some requests, or you'll have some requests put out there where you need efficiency gains, where there is also quite a history of many organizations trying to squeeze the penny to get more juice out of it, but it's like diminishing return. While it looks cool, but management also says, okay, the cost of you making the change could be very well offsetting the very, very, very benefit that you're going to get me. So those business cases are becoming fewer in number, and innovation is what I'm assuming the management is seeking more. But what are you seeing? What is so-called, what are they buying versus you trying to sell?
Right. I think a fascinating split, at least with where we live in healthcare, is how much of this is going to come from some of our core suppliers is just features, because our core suppliers will have AI-enabled features, no different than they've been releasing features all along to us through upgrades and those. And so I feel like part of this story is going to be AI-enabled features through the large vendor relationships that we have, including Microsoft. And so not as a sales, but Microsoft owns Nuance, and Nuance has a product for ambient listening. This is very popular in our industry of healthcare. You basically record the whole session that a physician would have with the patient in a clinic, and then the recording will summarize it in all the relevant parts that we have to document within an electronic health record. What's the history of the present illness? What are the orders coming out of today's visit? Are there any referrals to other points of care? Are there any medication orders, therapy orders? Is there a summary, and is there a code for that visit? And so some of the suppliers, there's a number of them out there, and it's called ambient listening, are really trying to use the technology of generative AI to be able to summarize the whole visit without the physician typing anything. And it will draft it out. The physician will review it, edit it if needed, and submit it. No different than some of our webinar technology, take meeting notes. It's a little of the same concept. And so I think in the spirit of how do we fund it, though, if I can go back to that a little bit, is as you're putting your budgets together, which is really about priorities. We have generally, when we end our reviews, it generally looks like 50% is in the keeping the lights on, so to speak, refreshing the network technology, refreshing the equipment. So let's call that 50%. About 30% is in upgrading, and you get functional enhancements. You get new things through upgrades. So that's about 30%. And then about 20% you want to reserve for some of those. In the spirit of your question, we know that, the actual benefit is undetermined, but we have to get our feet wet in some of these technologies. We have to understand where this is going, because it is going to be so transformational. And so we reserve maybe about 20%, maybe we could tell that 15% of the funding for that. You don't want the refresh to consume everything, and you don't want the innovation to not allow you to make enough investment in security. And so, I think if you walk in with almost your own mental split is a good habit. Should it be 50, 30, 20? Should it be 50, 40, 10? That kind of keeps you honest, because as we all probably, any CIO in the audience will know, there's 156 proposals for the smaller bucket of funds. And so if you look at all those proposals, and if you can start to put them in these big buckets of the keep the lights on and the growth and then the innovation, I generally think that bucket looks like 50, 30, and 20.
So healthcare, of course, is a noble profession, and it's about saving people's lives, but it's also a business. What do you think is the management in today's day and age, when value-based care and other areas where patient outcome is somehow becoming part of the regulatory requirement, that they have started looking at from that lens versus how can I save a buck, or how can I open more hospitals? And how are your IT budgets and allocations are being built, like the business case you built, and what they approve or reject? How much of that is attributed to how much value to the patient is being delivered, or is it more of a PR aspect or a soft benefit only?
Yeah, so we at University Hospitals are big champions of this move to value-based care. And so members of your audience that don't live in healthcare, I'll briefly explain, then I'll go into how we're doing this. So in traditional medicine, we get paid for every time somebody comes in the door. You get paid for every ED visit. You get paid for every admission to a hospital. You get paid for every physician visit. There are very smart people that say, wait a second, there are times where we can do some preventative medicine, and we would prevent the follow-up readmission. We could prevent the follow-up clinic visit. In a traditional business mode, that would be counterintuitive. You're doing things that prevent your customer from coming back in the door in the future. Like, why would anybody do that? But in healthcare, being mission-driven, we want to keep people healthy. That's our mission, is to keep people healthy. So we are a big fans of this move to value-based healthcare, which basically is record the outcomes over times for your patients, and we'll pay you on those outcomes over a longer period of time. Keeping people healthy and satisfied is an outcome in and of itself that you'll get paid for, kind of in short. And so we're big champions with that. We have a large value-based plan, accountable care organization, what it's called in our business. And so from an IT perspective, that's a big area of focus. And so what that means is we do prioritize investments in analytics to be able to show that, outcomes are improving over time through a change in clinical practice. For instance, if you give patients 30 days of medication when they leave the hospital, it is less likely they get readmitted, 8 days from now. And that's a very simple, for instance. If you call in and check on them after they've left the hospital, do they have the education? Do they have the transportation? Do they have a family member? Do they need a community member? These are all things we can be doing that keeps that patient from returning to one of our hospitals. So it's good, but it in and of itself comes at a cost. So from an IT perspective, that's a prioritized area. of population health, two big focused areas are analytics, being able to show, and then really workflow coordination in some of the packages, making sure that workflow coordination across home care, inpatient discharges, the follow-up orthopedic visit, that it all gets coordinated very well. So I think of value-based care, which is a little bit of a trendy term, really being coordinated care. And as a health system, if we can coordinate that care better for you, the patient, then you win as a patient, you're healthier, and you get your needs met. For anybody that has suffered through at least Western medical treatments, there can be boy, I got to figure this out on my own. And, nobody pays attention until I'm in the clinic for 12 minutes, but I don't have an overall coordinator. So we have large investments in the coordination of the care of the person outside of the individual treatment episodes.
So the way I heard you, you're saying while the outcome is the value that's delivered to the patient, but internally you translate in your business case that if you do better coordination, is going to build a better outcome for the patient, which in turn our own reputation, and also nobody loses, everybody wins. And that's how you're presenting your case, and that's how you get the money to do the job that you're trying to get done.
That's right, because that's right. In value-based care, the payer, one of the biggest payers is Medicare. The payer will say, what's the cost of the care for this patient throughout all of last year? And if that cost can be lower, they give you a bonus, roughly speaking. And the oddity about healthcare is that the higher the quality of care, meaning your outcomes are better, it actually is lower cost. But it might not intuitively drive higher revenue. If we just use the traditional business model, just more volume, higher revenue, higher cost, in some cases might be the objective of the business. And that is our mission is really why we show up for work. And so this move to population health or value-based, or I call it coordinated care, the more that we can get payers like Medicare to pay us a bonus for keeping costs low, keeping quality high, which are outcomes, including patient satisfaction, then we feel like that's going to be a winning strategy for us.
And with all of this happening, of course, you keep asking for more money and, of course, doing a lot of things to improve. Now, your team needs to be by your side. They should be intrinsically and extrinsically motivated to carry this through within the budget and the outcome that you had promised. And that workforce also comes at a cost. And that cost is not going down anymore. What is it, your budget? What does it look like when it comes to investment in not human resource, which is the term resource means you're going to squeeze the last drop out of it. It's more human capital, which you bring, you nurture, and you build it to its maximum potential. How's that put in the kitty or in your plan so that you do not skimp on that side, which is what's going to make every one of your initiative truly successful?
Right. I appreciate you bringing up that question of our people, our culture, our skill set. We're big believers in making sure our folks, at least on the IT team, have the skills and training for them to be the best partner for our clinical areas. So we have a relationship model at UHIT, and so we have folks that are dedicated to being the technology partner to cardiology, for instance, to emergency medicine, to intensive care, to outpatient clinics. And so part of that skilling is that they understand and are certified in the tool that we use. We happen to use Epic. There's other products in the marketplace. And so one training is to have one skill set is have thorough training in all the configuration options of our program called Epic. That allows, the more that they're trained, the more individuals can be efficient to listen to what the customer needs in a department, how they want to coordinate the care better, and then understanding the configuration choices we have in our package, and being able to set the configuration choices, test it, and then put it into production. And so on one hand, I think it's the skill set of understanding our packages well. On the other hand, it's I'll say the soft skill set of almost the interview technique, because at least what we do in UHIT is a majority of our time is that interview process of what are you seeking to do? What are you seeking to achieve? What's the outcome you're looking for? And then we spend a lot of time trying to map it to a build within our IT system. And then we put in, we'll call it a build ticket. That build ticket piece that's the least problematic for us in a general sense. Like, oh, go make the change in the IT system. So we probably spend 80% of our time understanding what the change is, almost being the liaison to the department, and 20% of the time actually making the change. And so wherever possible, we try to build those relationships with the departments, so that we can already understand where they're going with their line of thinking in the request. And as you can imagine, they don't typically put their what they want to do in IT speak. They typically don't talk about the tables that have to be adjusted. So the more that we live with them, the more that we will understand that, how their request will map to a change in the IT configuration. And since it's a single system, we have to be cognizant, just because cardiology wants one thing, this same workflow may impact urology. And so we want to be skilled enough to be able to do that efficiently.
And when we talk about all of this, people don't want to lose their shirt in the process, which is security. So you have to be able to at all times say that while I'm going to rip things apart, I'm going to rebundle them, reassemble. Security is going to be very key, and it has to be, it's a culture of security that you have to put in. And I'm not sure in your organization whether security is a peer to you or is it reporting to you. But regardless, information security is becoming very important. And that requires the investment. And then also we know that there is nothing like 100% foolproof security, which means there is a certain risk profiling that needs to be done, or tolerance of how much risk can you afford. And then you allocate dollar amount. So how does that go about when you are trying to change the tire of a moving car, and which is going to be a different tire as we go along, as we bring AI and other kind of interesting technologies where we don't even know where to put security in where everything is kind of fluid. So budget comes into play, unknowns come into play, 100% guarantee you cannot give for security. So then how does one go about allocating budget to it and then making full use of it?
Yeah, we often have discussions with our audit and compliance committee of our board of directors on information security. And it is such a priority given the news in the marketplace. That's been really the best champion,
Yes.
Unfortunately, of the criticality of information security. But our approach is to be very systematic or systemic in our approach. And so we talk about our roadmap with our board all the time. We talk about, right, if you need to protect a house, you have to close the windows on the fourth floor, and then you have to lock the doors. Then you have to turn on the alarm. And it won't prevent everything, but boy, if you have your back door open and then you say, oh, it's if not, it's when, not if, but you're not doing all the basics. So we talk a lot about encryption. In patching is the hand washing of information security. We have to encrypt all of our data. We have to patch all of our systems in a timely manner. Right? That's the hand washing of information security. And then on top of it, we talk about system administrators have to be protected. And that's a tool called privileged access management. And then we start from philosophy. The bad guys already have our username and password. So if anybody lets a login with just username and password, that's kind of like the back door's open, right? They already have your password. So you have to have two-step authentication, multi-factor authentication on top of it. And then we have monitoring tools, endpoint detection and response. And so that if there is a ransomware on one, so we talk about that layer of, well, when bad things happen, how do we not make it worse? And so that's a series of tools. So we often talk about this layers of security. And so we get them acclimated. There's about 16 layers in this whole cake. All right. And so we start with the fundamentals, know identity management, know who is out there and what they're supposed to have access to. And then you get to the login structure, and then you get to system administrators. And so you just kind of work up. And so when we get with hopefully a level of pride and not a level of arrogance, when we get these news that X and Y organization has had that event, does that change our approach? We look at our approach. In almost all cases, we say no. No, we need to continue to work up this cycle of, right, it's climbing the mountain. And we get that audited by an outside company every 3 years thoroughly. Are we doing all the right things? Don't trust us. Are we really, do we have a high percentage? And so we usually get high marks. Like you said, no guarantees. And so that's what I would almost encourage your audience to really not use the fallback of, well, it's not if, but when. Really try to answer the question of, can you explain with clarity the layers of security that you have protecting over and over again your data, and what you do to prevent, if one fails, you should have two that still protect. That's the right way to approach it. And if you read a report that a system administrator has been hacked and the keys of the kingdom was given up, like, your response should be, here's where we are on privileged access management, PAM, and here's how system administrators have to go through these hoops to get a one-time password checked out to make any administrator change. And it's those type of, that's the approach we try to take. Information security does, the CISO does report to me. In my past role, I was the CISO in addition to the CIO. I'm very attuned to this world, and I think it's about that conversation with your audit and compliance board and the confidence of, here's what we're doing. No guarantees, but here's what we're doing to protect our house. And we're not leaving any of the first floor doors and windows open. And if you are, the concept of that, then the multi-factor authentication would just be one example. Nobody should have user access remotely with just username and password. And so those are the type of techniques that I would guide.
One last question about the DNA of a leader in healthcare, in IT, which will give them all the gravitas, the executive presence, the emotional intelligence to do the best with the limited healthcare IT budget available and do all that they are supposed to deliver. What should be the mindset, the leadership style of a healthcare IT leader, which will allow them to be effective for times to come?
Yeah, Sanju, this is it's really a great question. And so even when you introduce me, I always introduce myself as Senior Vice President and CIO. And that's intentional, not out of arrogance, but out of, I'm a leader in the organization first before I'm CIO. So I would say, to your question, you really have to understand how the business runs. You really just do. If you're in healthcare, you have to understand how we're funded and how we have funding through various ways. You have to understand how the employment mechanism of our providers or physicians are done. These are all unique characteristics of healthcare, at least American healthcare. And so you have to know how the business is run, and don't feel that it's beyond you. You're an executive. You should know how the business is run. And so I try to spend a lot of time understanding how the business is run, how we get funded, the pressures on our expenses, outside of IT. So then I can plug in and I can have context for my corner of the world, which IT, runs so much of any business in 2024. But that would be my my guidance, and it's a little technique to put your vice president or your senior director and CIO is almost a mental reminder. You have an obligation to the business first before you have an obligation to IT.
Great advice. So thank you so much, Robert, for sharing the insights on how we can handle the healthcare IT budget in such a way so it gives you the efficiency, it gives you the innovation, it gives you the security, it allows you to be compliant and come out as a winner. So thank you.
Thank you. And thanks for the opportunity.
Absolutely. And listeners, please subscribe to our podcast and join our new YouTube channel. And this is Sanjay Gaul, your host, signing off. Till next week, take care and God bless.